All right, I'll get started with my pre-presentation spiel here. So welcome to concurrent session C2, Who Can I Call? Gathering the evidence on crisis intervention, questioning involuntary treatment, and minimizing harm. My name is Kim Farrell, and I'm joined today by my colleague Francine Burke. We will be your facilitators for this session. Before we get started, I'm just going to review a few quick housekeeping notes and then introduce our speaker, and we'll get started. Please draw your attention to the bottom of the screen. You'll find the Zoom toolbar. Please use the Q&A feature to submit questions throughout the presentation. We'll review them at the end of the session and do our best to answer as many as we can as possible in the time that we have. We do ask you to use that Q&A so that we don't have to scroll through the chat to find questions at the end. Please do ensure that your microphone is off or on mute until the end of the session with the Q&A. And please note that this session will be recorded to be uploaded to the conference website for future viewing for folks who have registered for the conference but who weren't able to come to this one. You will be able to access that for 90 days following the conference. Also like to remind folks that there is closed captioning available for all sessions. You can click the CC icon below the video window on your screen to access that function. At the end of the session, we will have an evaluation that is available. You click on the session in the agenda on the virtual platform itself, and there's a survey button next to the join button on the session. All feedback is greatly appreciated and helps inform future events like this conference. We would like to respectfully ask that all those attending today's session engage with each other thoughtfully and always consider the impact of your words and interactions on other folks. As facilitators, we will not tolerate any abusive or inappropriate behavior or hate speech and will ensure that anyone who engages in such behavior is removed promptly from the session. If you have been disturbed or affected by any such event, please do what you need to do for yourself. Take a break, step outside, practice some deep breathing, or reach out to someone you trust. If you are in crisis and require immediate support, please click on the FAQ icon on the FAQ icon, on the conference homepage to access contact information for Connects Ontario. And if you would like to report an incident, contact event manager Sherry Sim by clicking on the assistance button at the top right menu bar of your screen to send an email, or text Sherry at 416. Whoops, I just went to paste it in the chat and minimized. 416 605 5975. And I will pop that in the chat for folks. So I'd like to now introduce the presenter for this session. Welcome Aisha Khan from the Canada Excellence Research Chair in Health Equity and Community Wellbeing at Toronto Metropolitan University. And I'll let you take it away.
Hi, Kim. Thank you so much. You can't see my screen right now, right? Sorry, technical difficulties.
Oh, yeah, we can see it.
You can see it?
Yep.
Okay. It says for me it's paused. So I'm just gonna stop and start again if that's okay. Alrighty.
Absolutely.
Okay. You can see it?
Yep.
All right. Thank you so much. Hi, everyone. Thank you, Kim, for a lovely introduction. I would like to thank you all for coming to this session. I know that there are quite a few concurrent sessions happening right now, so I appreciate you taking the time to attend my presentation this morning. I'm hoping for this presentation to be also like a workshop and present as a learning opportunity for you as the audience, but also for me. So if you already haven't, I would love it if everyone could take a moment to introduce themselves in the chat as well as their position and organization. I do have an interactive component throughout my presentation. Kim, if you could actually share the link right now as well with folks, thank you. I would love for everyone to participate. So just knowing where everyone is situated within the health and justice field as service providers is very helpful. I myself work in academia, but within the realm of community engaged research, and much of that is driven from interdisciplinary approaches in partnered projects such as this one, and also by receiving input, insights, recommendations from folks like you, people who are out on the field working frontline delivering care. So please don't be shy. I'd love to meet you as well. Thank you. All right. So my name is Aisha Khan, and I work as a research assistant on the project Who Can I Call? Gathering the evidence on crisis intervention, questioning involuntary treatment, and minimizing harm at the Canada Excellence Research Chair in Health Equity and Community Wellbeing. Before we start the presentation, I would like to offer a land acknowledgement and acknowledgement of country. I acknowledge the traditional owners and custodians of country and land throughout Canada. We acknowledge the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto or Tkaronto is covered by Treaty 13 with the Mississaugas of the Credit. I would like to pay my respects to elders past and present, acknowledging First Nations people's shared experience and impact of colonization onto their health and well-being, their families, kinship networks, and communities. We recognize the sovereignty of all Indigenous nations as the original inhabitants of these lands and waters, and we give thanks for the opportunity to work, live, and play on this land. As a daughter of immigrants, I recognize that I am a settler on these lands through my parents' journey across the globe, and I'm grateful to be here. I urge us all to continue to learn about the Indigenous peoples and their rich history and traditions wherever you may be situated. Thank you. All right, so this is the agenda I have for today. It's also on the worksheet, so feel free to take a look there. This is a reminder to use the Q&A function in Zoom if you have questions. We will have a dedicated portion to that afterwards. And so please use the Q&A section on Zoom instead of the chat because we don't want any of the questions to get lost. All right, so this project has been funded and supported by the Canada Excellence Research Chair in Health Equity and Community Wellbeing. This project is based on a collaboration with the CERC in Health Equity and Community Wellbeing at Toronto Metropolitan University and the Gerstein Crisis Centre. With a 35-year history of providing 24/7 crisis intervention services, the Gerstein Crisis Centre ensures that individuals experiencing a mental health crisis receive immediate and compassionate support. The Social Sciences and Humanities Research Council of Canada, or SSHRC, has also awarded this project a Partnership Engage grant. So just a little bit about the CERC, led by Dr. Karen Soldetich, the Canada Excellence Research Chair in Health Equity and Community Wellbeing, is a transformative research initiative that employs an engaged community partnership approach to expand our understanding, practice, and delivery of health outcomes for all members of our communities. Through collaboration with a network of healthcare institutions, service providers, and civil society organizations, the program aims for a paradigm shift, one that challenges a siloed, expert-driven approach to health and well-being and moves instead towards a community-engaged, preventative model of well-being. Uniquely applying a critical disability lens, the research program aims to not only reduce health disparities that are inextricable from their social context, but to also embed community knowledge into healthcare institutions, systems, and models of delivery. This project is situated in the social determinants of health and community well-being stream at the CERC. So I'm sure you all are familiar with the social determinants. They are the conditions under which people are born, grow, live, love, work, and age, and they include factors such as education, employment, and social support networks. These structural determinants of health are the broader socio-political support networks, and ecological contexts that shape these more proximal social determinants of health and in turn shape population health and well-being as a whole. So drawing on and expanding upon the World Health Organization's definition, we expansively consider social, the conditions of living throughout the life course, structural, which is the socio-political, economic, and ecological context, and indigenous determinants of health, for example, loss of land, climate destruction, whole community health, the role of reconciliation, the role of culture and language in health, and much more, and how all of these interact in complex ways to produce health outcomes. We also consider the interplay between these, such as how social location and living conditions are influenced by structural factors that determine a person's vulnerability to risk, the resources that are available, and other mitigating factors. And research in this stream aims to understand how inequitable social factors and relations reproduce themselves, become entrenched, but may ultimately also be disrupted. So this CERC stream encompasses the United Nations Sustainable Development Goal SDG 3, which is good health and well-being to ensure healthy lives and promote well-being for all. And if you take a look at this diagram I have on the slide, there are several components that contribute to the social determinants of health, including spatial dynamics, socio-identity, barriers, housing, accessibility, income, education, gender, culture, race, and many more. It is a long list, but it also includes community-driven models of health and well-being, which is central to this project. And this project focuses on addressing the social determinants of health of crisis care service users and advancing upstream preventative models of care through a critical disability and intersectional lens. By partnering with Gerstein to investigate non-medical crisis interventions, this project challenges the siloed, expert-driven approaches to mental health and substance use, and these are usually prioritized. But here we're mirroring the healthcare delivery paradigm shift in the WHO's new guidelines on mental health, and also in alignment with the central objectives of the CERC. Because one of the CERC's mandates is also to bridge academic research with community-driven solutions, fostering this model of well-being that centers equity and accessibility. All right, so crisis response. Current crisis response frameworks typically rely on police intervention, often leading to criminalization or unnecessary hospitalization of individuals experiencing mental health crises or substance use-related distress. And what these approaches do is they fail to address the complex social and economic factors that contribute to crises, particularly for people who have historically been underserved in society. In Ontario, the increasing frequency and intensity of crises stem from multiple structural issues, including a worsening housing crisis, a growing opioid epidemic, and insufficient financial support for disabled individuals. Our research seeks to explore alternative crisis intervention models that prioritize non-medical, community-led responses without police intervention, thereby addressing a significant gap in policy and practice, which also speaks to the conference's theme of justice begins early as we advocate for policy change with evidence-based research. So many individuals in crises experience multiple intersecting challenges such as mental distress, substance use, financial instability, and social exclusion. The current crisis response strategies also disproportionately impact racialized and disabled individuals who are at the highest risk of being harmed or killed during police interactions. Despite widespread recognition that law enforcement is ill-equipped to serve as first responders for mental health and substance use crises, Ontario continues to rely on punitive measures, such as involuntary treatment programs and the closure of supervised consumption facilities rather than evidence-based, right-centered interventions. So that actually brings us to the first question that I have for you in the worksheet. Kim, if you could share that again, thank you. The link for anyone who missed it. My question for you all is, what does community-based crisis intervention look like to you? How do you define non-medical intervention? What language is being used? As service providers, how do you talk about this across different sectors? It doesn't need to be in full sentences. This is a space for brainstorming, putting down keywords. You are welcome to sign what you are writing by adding your name and a colon, like in the example I have on the worksheet. Or if you would like to add your thoughts in anonymously, that's all right as well. This worksheet will also be shared on the platform next week after the conference, and I'll keep the access open on the Google Doc as well if you remember something later in the day and you would like to add. I'll give you about a minute or so to do that. I'll actually go to the worksheet right now. Let's see.
I was just going to say, if folks don't want their name to show up while they're typing, just make sure you're signed out of Google on your device, and then you'll show up as anonymous. Otherwise, if you're signed into Google on your device, it'll pop your name up there. Also, I love seeing the anonymous names that Google assigns people, like anonymous hedgehog, anonymous lemur, anonymous pumpkin. It makes me giggle every time.
Blobfish, that's a new one. Oh, penguin. Just reminds me of like when you're in school and you have a group project and everybody's on the dock at the same time. Thank you, everyone.
Oh, I, that's making me feel a little old, Aisha. There was no such thing as multiple people working in a document when I was a student.
Oh, I apologize.
No, it's wonderful. I'm glad the technology keeps evolving.
Yeah.
Mostly happy.
COVID really changed the game.
Absolutely. Yeah.
All right, I'm going to go over a few of these. They're great. Thank you so much, everyone. Timely responses, non-judgmental, um, helping folks in their community, not a hospital. Oh yes, peers, crisis planning, crisis response teams, working in tandem with police and emergency services. All right, with multiple modes of access. Okay, thank you, everyone. Okay. Everyone can see my screen, right? I'm going to do that every time. All right, thank you. All right, so that brings us to our project, Who Can I Call? Our title is actually an ode to our first team meeting where we had a discussion which led to the question that during a crisis situation, does the public, do our communities know the alternative organizations or numbers to call instead of the police? And the answer is that for the most part, people just know 911. That's what you grew up learning, being told that in an emergency situation, you call 911. So a part of our project is to definitely shed light on alternate pathways to access community-driven care, especially. And this is highlighted by the visual representation that access points all look the same, but they are different in terms of processes, care, support, and impact, as many of you alluded in your responses. So this project is a two-stage project between a multidisciplinary research team and Gerstein. Stage one has various components, including a literature review on involuntary treatment, a scoping review on community-based crisis interventions around the world, narrative profiles built from an urban crisis center's internal data, so Gerstein, and a study of crisis worker interviews. So the second stage will focus on mobile care teams and involve additional community partners. But this presentation is focused on stage one because that's where we are right now in our timeline. So our partner, the Gerstein Crisis Centre. Gerstein is an urban crisis care organization offering a range of services and programs, including a telephone crisis line that receives more than 30,000 calls per year, mobile care teams, community-based crisis beds, referral services, and peer-led group activities, and much more. Gerstein has been around for 35 years, and they provide 24/7 crisis intervention services, ensuring that individuals experiencing a mental health crisis receive immediate and compassionate support. They have a right-centered approach, which emphasizes non-medical recovery-oriented care, which aligns with the partnership's goal of fostering person-centered accessible health services. And a 2023 case study by Human Rights Watch pointed to Gerstein Crisis Centre as an exemplar of community-based mental health crisis support. This map provides a high-level overview of what the Gerstein Center is and what they do. They've been doing this work for a long time, since the late 80s, and they are an alternative to police. They are a police alternative to crisis response. So what happens is if people are having an immediate crisis in the city of Toronto, they're welcome to call the 24/7 line. There you are connected with a crisis worker who can help walk you through a crisis situation that you're having, if it's regarding yourself or a loved one, a family member, a colleague, or really anybody, as long as you're over the age of 16. Gerstein has two direct lines, the crisis number, as you can see on the screen, as well as 988. They are one of the partners in the National Suicide Prevention Line, so they have trained community crisis workers that are able to receive those calls and walk somebody through their crises. And also attached to the services is a mobile team, so these teams can come out to you and see you, and the crisis workers can meet you in real time and really walk you and through and guide you through your crisis. Gerstein also has crisis beds for short stays attached to this service where people can get a little bit of rest, for 2 to 3 days, kind of regroup, get the support that they need in-house, and then they're able to return back to their home or wherever they may be staying. There's also the crisis support at the Toronto Public Library, which offers low barrier crisis support programs to library customers in a welcoming, judgment-free environment. So through this partnership, GCC and the Toronto Public Library provide crisis management, follow-up support, referrals, community connection, and peer-led recovery groups, as well as different activities such as the Finding Recovery Through Exercise, Skills, and Hope program, Fresh, and Wellness Recovery Action Plan WRAP program in 4 of the Toronto Public Library branches. The crisis teams, these ones can help with short-term counseling, mental health support, primary care services, connecting with housing workers, substance use supports and resources, as well as financial and employment supports, and wellness and recovery programs. So Gerstein does a lot of community collaboration, and that was just one program that I was talking about at the Toronto Public Library. Their work is very much guided by people with lived experience and living experience, and they also have a variety of advisory groups to help guide that work. So the philosophy behind each of their programs is that the Gerstein Centre has an approach to crisis that respects the individual's ability to define their own identities, experiences, and goals. Hence, they follow a strengths-based approach, which is based on coordination, equity, and access, empathy, collaborative problem solving, as well as harm reduction. So this project co-develops solutions with Gerstein, the frontline service provider, and therefore through this collaboration, we're advancing evidence-based alternatives to involuntary treatment, but also strengthening the capacity of community organizations like Gerstein to advocate for systemic change. And this also reflects our values of the CERC, our broader goal of transforming health systems through participatory, justice-oriented research. So this is our research team. Most of us are based at the Toronto Metropolitan University, or TMU. Dr. Jessica Evans is the principal investigator. She couldn't be here today, unfortunately, which is why I'm the sole presenter. But Jessica is an assistant prof in the Department of Criminology, alongside Dr. Karen Soldetich, who is the CERC in Health Equity and Community Wellbeing. We have Danielle Landry, our research associate, as well as Dr. Marina Moreau from York University. She's done quite a bit of research in this area, and she's also served on the board of directors at Gerstein. And last but definitely not the least, we have Susan Davis, who is a total powerhouse, Gerstein's executive director. You may have also heard of her because she is also the chair of the Downtown and Toronto Regional HSJCC. So I'm here today because Susan. All right, so the goals for our project, especially for the first stage, are to build an evidence base of non-medical crisis interventions without police and carceral responses, identify, map, and document key features of effective non-medical crisis interventions, drawing upon international models. We also want to collate the existing evidence on the purported harms and benefits of involuntary treatment for mental distress and substance use crisis. And lastly, we want to generate new knowledge about the experiences of people who are accessing non-medical crisis support and their short and long-term outcomes by conducting and analyzing interviews with the community crisis workers and conducting an in-depth case study of client records, feedback forms, and reports, as well as interview data. So our research questions for stage 1 are essentially broken down into 2 categories. We have effective non-medical crisis interventions and involuntary treatment for mental distress and or substance use. We're essentially looking for key characteristics, gaps that exist between literature and practice, the demographics of Gerstein service users, etc. Who accesses crisis services in Toronto? What social factors lead them to be there? What policy recommendations can be made? And what does the existing evidence suggest about the harms and benefits of involuntary treatment for mental distress and or substance use crises? So our research activities include a scoping review focused on international models of alternative crisis interventions, a literature review on involuntary treatment for mental distress and or substance use, and after conducting an analysis of GCC's underused internal data, we will be creating narrative profiles to understand the realities of how people experience community-based crisis intervention. We're looking at client records, feedback forms, aggregate reports, as well as conducting interviews. And combined, we're hoping that this data will better inform Gerstein's models of service delivery, in addition to contributing to the development of evidence-based public health policy responses to mental health and substance use critical crisis care. So this study is grounded in anti-racist feminist theory, mad studies praxis, and survivor research ethics, emphasizing the lived experiences and living experiences agency of those impacted by crisis interventions. Additionally, critical criminology and qualitative health research methods will guide our analysis, challenging medicalized and carceral approaches to crisis response while highlighting structural and systemic factors that influence harm reduction and service accessibility. This project uses thematic and narrative analysis, and for our scoping review, we use the Prisma framework as well as the Joanna Briggs Institute method, the JBI method. Our scoping review also includes peer-reviewed academic literature as well as gray literature, such as policy reports, community-based research, program evaluations to ensure broad and inclusive evidence base, both local and global. So addressing coercive practices such as involuntary admission, involuntary treatment, seclusion, and the use of physical, mechanical, or chemical restraint are widespread in mental health services globally. However, there is no evidence that these practices offer any benefit, while significant evidence shows that they cause physical and psychological harm, dehumanization, trauma, and worsening mental health, as well as eroding trust in services. These practices can also negatively impact family members, mental health professionals, and it also discourages young professionals from entering the field and demotivating those who are already there. This was really prominent during the pandemic, for instance. This is all from the World Health Organization's guidance on mental health policy and strategic action plans, which came out in March of this year. This is a series of modules that address mental health policy solutions. And policy here plays a crucial role in promoting coercion-free services. It should stipulate training for mental health professionals to understand the harm caused by coercive practices and to develop their capacity to implement non-coercive approaches such as de-escalation techniques and effective communication, even in crisis situations. Policy can also encourage individualized planning, including crisis plans, and the creation of response teams skilled in handling and challenging situations, and ensure quality assessment and improvement mechanisms are available, as well as effective complaint mechanisms for coercive practices. So our literature review actually considered recent literature on the purported harms and benefits of involuntary treatment for mental distress, crisis, and or substance use. The overall assessment of involuntary treatment is that there is a lack of credible and reliable evidence to support its use. These studies critique existing methods, citing inconsistency across the programs and outcome variables measured, low numbers in trial and loss of participants for follow-up, and the overall lack of randomized and controlled trials. Within the studies that cite evidence of positive outcomes, these have been statistically non-significant findings, with only one study citing a moderately significant outcome. Furthermore, the majority of studies critiques a lack of a controlled group or a comparison to outcomes from voluntary treatment strategies. And this is the second common theme that we observed, which questions the outcomes most frequently cited as positive, which is treatment retention. One of the studies notes that retention and treatment while under a civil commitment order is a questionable outcome to measure given the compulsory nature of treatment. We also saw a handful of studies looking at the demographics of people subjected to involuntary treatment, and many studies found that unmarried men diagnosed with alcohol or opioid use disorders face heightened risks of being subjected to involuntary treatment. Another study also found that unmarried men who were unemployed that did not have home or school obligations were more likely to be placed in involuntary treatment. So Kisley et al., that's a study, also found that individuals from culturally or linguistically diverse backgrounds were 40% more likely to be ordered into involuntary treatment. So what does this tell us? The demographic composition of involuntary treatment individuals suggests that first, the focus is on unemployed and unattached men, pointing to social stability and community contact as important protective or preventative factors. This finding provides support for greater community-based interventions, which can alleviate the instability and solitude experienced by people who use drugs or who have complex psychiatric diagnoses. And the second suggestion derived from this demographic analysis is that the variables beyond the severity of a person's substance use disorder or crisis factors into the decisions about who is placed into involuntary treatment. So this indicates that decisions for involuntary treatment placements are not made exclusively about the risk of public safety or harm to self, but are influenced by institutional and political culture. And this would raise serious ethical and human rights concerns around conditions under which consent to treatment can be overridden. And so given the lack of rigorous controlled studies assessing the efficacy of involuntary treatment, many argue the benefits reported are achievable in a voluntary setting. The issue is the lack of availability and appropriateness of voluntary treatment options, a lack of community connections, a lack of upstream solutions. And this is particularly relevant when considering the demographic makeup for those most at risk of being subjected to involuntary treatment. They often lack social stability and community contact. These are things that could be more appropriately addressed through community-based and voluntary accessible services. And this is important because, and many of the authors raise this concern as well, that if the focus is on involuntary treatment, it diverts necessary attention away from resources being put towards voluntary community-based programming and services. The lack of access to these services as funds and attentions are diverted to compulsory treatment is likely to push those who have even voluntarily sought out support into greater precarity because they're placed at an increased risk of involuntary treatment. And under these conditions, involuntary treatment is indefensible from an ethical and human rights perspective. Okay, so now our scoping review, it looks at community-based crisis care, whereas our literature review was looking at involuntary treatment. So for our scoping review, we started off by determining our search strategies, which include search terms we are using to search for the articles. Our population is people experiencing substance use or mental health related crises. So some of the terms are here. Mental disorder, mental health crises, you can see them on the screen. The intervention is non-medical or non-police crisis interventions. So we are not comparing interventions and we're also not measuring outcomes. We're really just trying to get a grasp of what is out there. So we're keeping it very broad. While using these search terms, we found that some of the terms gave more relevance and a greater number of articles than others. For instance, substance use or substance abuse paired with community-based crisis interventions were search terms that worked the best. It was also very important to make sure that an article didn't discuss medical or police interventions, as this is something we aren't looking into. So there are some mobile crisis interventions that include a police officer paired with a mental health worker or a nurse, but we're not looking at those. So those were excluded based on relevance. We're also looking at studies with adults. However, Gerstein itself is for those 16 plus. So we took out studies that were focused on just adolescents, but we included the ones that have an age range from like 16 to 27. Even though it is under the age of 19 or 18, it's still the same intervention across the board, regardless of age range in that group. Okay, so now that brings me to the second question. So Kim, if you could share the link again, thank you. So our second question, I want to take a moment that before I talk about our scoping review further is to actually discuss with you what is a crisis. That is probably the word that I've said the most today. But what does it really mean? What does it look like? What does it sound like? So if you could pull up on the Google Doc worksheet I shared with you, and take a few moments to write in your thoughts as you collect them together. You know, what comes to your mind when I say the word crisis? What does that mean? And I really want to preface this and say that there is no wrong answer. We're really trying to capture the scope of this, and we recognize that there are blurring boundaries when it comes to definitions. So we want to better understand that to inform our research and our recommendations. And actually what we've come across in our own research while we're doing the scoping review is that the definition is so broad. We knew that we were going to come across environmental, humanitarian, natural disasters, which would be written as crisis in the literature, but those would be excluded because that's not necessarily what we're looking at. But what we've also come across is so much on mental health in the pandemic, school shootings, and the opioid crisis. So you know, we'd love to see what your insight is as service providers. So I'm actually gonna pop over there and see what you guys have written. Oh, okay. Yeah, a state of being overwhelmed and having nowhere to turn. Oh, I started reading in my head. Let me read some of them out loud. Something that is very different from the individual's baseline emotions, behaviors, and attitudes. Someone who is escalated and behaving significantly about their normal baseline and are experiencing significant distress, fight or flight. Yeah. However, some of the folks we are sent to respond to as crisis workers are not necessarily in crisis themselves. Rather, they have had police called on them because these individuals are seen to be socially disordered and not meeting societal expectations. No, well, this is all great. Thank you. One of the reasons we wanted to pose this specific question is because it was brought to our attention that this was someone like you all, actually a service provider, that when they heard about our project, they asked us, what did we mean when we say substance use crisis? What is a crisis? Because in their world, a crisis is an overdose. And it's in these definitions where the boundaries between mental health and substance related crises become blurred. So if someone is experiencing altered states, they can get labeled as drug-induced psychosis, for instance. Available crisis interventions will likely be categorized as mental health initiatives. But very few will also simultaneously attend to the drug use dimension. So while responders might carry naloxone, they probably won't be equipped to ensure that the person in crisis isn't separated from a reliable drug supplier or protected from entering withdrawal. So it's also about like looking at that timeline of care and that response. All right, thank you, everyone. Okay. So, um, this is all going to be very helpful again, because when I actually ran the first search for our scoping review, we came across terms such as peer respite, and which is a popular term in the States for these kind of programs. So then I went back and ran a search for that too, and we were able to yield more articles from there. So I really do appreciate your input. So for our scoping review, we mostly completed screening for articles, and we're using Covidence. We have a total of 848 articles from various databases, such as CINAHL, PubMed, PsycInfo. We're on the full text stage, but we've kind of been flipping back and forth a little bit because we are also including gray literature sources. And those aren't necessarily found in the traditional databases. So our approach is to read through each source, reach out to as many people as we know, tell them about our project and ask, which organizations are doing this kind of work, who can we refer to? And when we are looking at what crisis intervention models are being mentioned or discussed, and then we're examining the effectiveness of each approach to crisis intervention. So right now, we currently have 153 organizations listed, and we were hoping to be able to find more articles than expected. So the next question I have, question 3, if you know any organizations that are doing similar work to Gerstein, I don't know if, so today you attended my presentation, but if you were at Circles yesterday, the CMHA in BC, that was such a fantastic presentation I got to attend, and definitely added that service to our list. So I would love it if you know anyone, any contact, please feel free to share names and links in the doc. All right, so our REB actually cleared 2 weeks ago for site visits. Again, multiple components in this project. So we're at this step currently where myself and the PI, Jessica, will be going to Gerstein over the next few months to access the de-identified client records. We're looking at 4 internal data sources. So some of you may have already heard of these measures, so I would love to hear your thoughts on these forms and maybe how we can best leverage them alongside our interviews. We're looking at 50 de-identified client records that will allow us to build a composite profile of GCC clients through detailed information on clients' previous interactions with the medical and criminal legal system, their current crisis, their access to material and social resources outside of the GCC, and their status upon exit. We're also looking at the Ontario Perception of Care, the OPOC form, which is a provincial tool to collect care feedback for clients receiving publicly funded mental health, addictions, and or concurrent disorder services in Ontario. We're also looking at IARs, the Integrated Assessment Record, which provides a high-level overview, system-level reports of demographic and operational data. This macro level perspective will help identify and illustrate key trends in service use over time, which will be beneficial for highlighting gaps and providing recommendations. So last question I have for you all. We're actually building our questionnaire for the interviews. We want our literature review and our scoping review, as well as our preliminary analysis of the internal data to inform the questions that we ask the community crisis workers at Gerstein, many of whom are peer workers, so they have lived or living experience. We'd love to know what it is that you would like to learn more about their experiences. What do you think that we should ask them? What would you like to learn from their experiences of doing this community crisis work? We're also curious to see, as you are service providers, what kind of barriers do you think that we will encounter in the site visits and or during the interviews? Okay, maybe we'll pop back onto the doc after I wrap up though, because I'm aware that we're almost nearing the end. So I also wanted to share one of our community outputs that was released in October. We'd like to invite you to listen to our Disability Dialogues podcast episode on this topic. You can stream it on Spotify, and there's also the QR code on the screen. Disability Dialogues is a podcast featuring the CERC researchers discussing research in a public-facing format in order to make this research and our findings accessible, but also why the average person should care about co-creating inclusive healthcare and well-being with communities. This particular episode is titled Rethinking Crisis Response, Building Community-Led Alternatives in Ontario with Jessica Evans, the principal investigator, and Susan Davis, the executive director at Gerstein, as well as a co-PI on this project. Okay. So this project has definitely more in store, but I'm very thankful for the opportunity to have presented the partnership today and our preliminary findings. I'm glad that this session was able to kind of work as a working group session. So thank you for participating in the worksheet. I know there's quite a few takeaways. This does bring me to the end of my presentation, so thank you for participating and listening. My contact information is on the screen, as well as our project page at the QR code and our published OSF protocol. So please feel free to check that out. I think we have about 10 minutes, 10, 15 minutes for questions. So yeah, feel free to use the Q&A function on Zoom and ask me any questions. Thank you all so much.
I'm not seeing any questions in the Zoom Q&A. Folks can also feel free to raise their hands, and we can call on you and listen to your voice here. Any questions? The QR says the campaign is disabled.
Oh, really? Okay. I'm really sorry about that. Let me pop the link.
Let me double check too. Yep, QR campaign has been disabled.
Okay, I'm gonna pop the link actually in the chat if that's okay.
Of course, please do. Any questions for Aisha?
That tells me I was thorough. Thank you.
Yes, it was absolutely thorough. Well, I'll leave a couple of minutes in case folks have questions, and then I'll do some wrapping up. Carmen says, no questions, but thank you. Very informative. Well, why don't I get to my end of session stuff, and if folks have any questions, please feel free to again use that Q&A function or pop your hand up. But please join me in thanking Aisha for a great presentation and for sharing so much wonderful knowledge with us. Please take a moment to fill in the survey for this session. You can find that by going to the agenda in the platform, choosing the session we're in, which is C2. And then next to the join button, you'll see a survey button. It's pretty quick and is very helpful for folks. We also encourage you to take some time to connect with fellow participants and visit the poster and exhibitor halls, where you can view poster presentations and connect with exhibitors, and feel free to add resources from the exhibitors to your personal swag bag. To build your own agenda, click Add to Calendar button uh, in the word left platform. We would also appreciate if you could take a few moments to complete the conference evaluation, which can be found by clicking the evaluation icon on the conference homepage on the menu bar. Feedback is anonymous, appreciated, and will be used to plan future events. Thank you once again to Aisha and every one of you for your participation. There is now an hour break for lunch from noon to 1 p.m. There is a lunchtime session if folks want to join from 12:15 to 12:45. That is Peer Support in Action, the Young Adult Cannabis Harm Reduction Digital Storytelling Project. Following lunch at 1, please join us for our keynote speaker, Guy Felicella. To join the keynote session, click on the agenda link on the menu bar and then join for the keynote presentation. The D series concurrent sessions will follow after the afternoon break at 2:30 p.m. And you can join those by following the same series that you did to get here. So clicking on the agenda, choosing the session in the series you want to join, and clicking join. And I'm not seeing any questions in the chat or in the Zoom Q&A. So thank you, everyone.